Lovely to be here, and thank you so much for the opportunity to present on Digital Navigators with my colleagues from various parts of the world. We have a lineup of a series of presentations to give, and then we will do some dialogue and take some Q&A at the end. So we are with you from 2 to 2:55 p.m. Eastern Time. As was mentioned, this is really a focus on the role of digital navigators and the implementations of the digital navigator role in the various contexts. So the first presenter today, and I'm going to do all the bios up front, and then we'll move to the presentation. So the first presenter is from the US, is from Boston, Mason Granoff. Mason is a clinical research coordinator with the Division of Digital Psychiatry at the Beth Israel Deaconess Medical Center, leading the team's community digital health navigation program. His work focuses on bridging inequities in digital care by providing digital literacy training in healthcare and psychiatric services. So Mason will start us off today. We will then go to Dr. Sean Kidd. Dr. Sean Kidd is here in Toronto, Canada, as am I. He's a clinical psychologist and a senior scientist at the Centre for Addiction and Mental Health, which is Canada's largest mental health and addictions hospital. The name itself doesn't give it away that it's a hospital. So I'd like to insert that there. He's also a professor at the University of Toronto Department of Psychiatry. His work has included the development of interventions for a range of different populations, including youth experiencing homelessness and individuals with severe mental illness. His digital health work has focused on the design and validation of A4I. You'll hear a little bit about that today, and his role as the co-founder and the chief scientific officer for A4I. There's a code happening in the background, so hopefully you're not hearing it over the in the microphone here, but I imagine many of you are working in clinical areas and understand that. We next have Laura Uchtmann. So Laura is a researcher in digital mental health at the Brandenburg Medical School in Berlin, Germany, and she is a psychotherapist in training. Her work focuses on implementation research and the integration of digital tools into outpatient care. And then finally, also from Toronto, Canada, we have Iman Kassam, who is the manager of the Digital Innovation Hub at the Centre for Addiction and Mental Health here in Toronto. She supports and leads digital mental health research in the areas of population mental health, implementation science, and knowledge user engagement. So thanks everyone for being here. I'll pass it over to Mason to begin the presentation today.
Hi, everybody. Thank you so much for having me. I'm just going to share my screen, so give me 1 second. All right, there we go. All right, thank you so much for that introduction, Gillian. So my name is Mason Granoff. I'm a clinical research coordinator and a digital navigator here at the Division of Digital Psychiatry at BIDMC. I'm going to be talking a little bit about what we do to actually train digital navigators that we implement on sites, both within research settings and at community sites around the greater Boston area. So while the digital transformation of healthcare has increased access for some, it has left many without technical resources and foundational skills behind, creating a two-tiered system between those who can access digital health tools and those who cannot. The purpose in general of implementing a digital health navigator is to bridge what is termed the digital divide in healthcare. And the digital divide is defined by the National Digital Inclusion Alliance as the gap between those who have affordable access, skills, and support to effectively engage online and those who do not. This divide takes the form of both physical access to technology and the knowledge to use it. So this is what we call the first and second order digital divide. So digital navigators are really aimed at overcoming this challenge in healthcare settings and preventing existing inequities in care being exacerbated. So a digital health navigator is a trained member of a clinical or community team whose goal is to support the uptake and implementation of technology into care. Their responsibilities can include providing resources such as low-cost broadband internet, troubleshooting technology directly with patients, providing on-site digital literacy training, in supporting the use of digital health tools by facilitating patient engagement and matching patients to those tools. However, as an emergent care role, this has required the development of training to ensure the competency and efficacy of navigators. So our 4-module training sequence that we built here at the Division of Digital Psychiatry in collaboration with other members of the Society of Digital Psychiatry is really aimed at building and assessing those foundational technical and interpersonal skills necessary for implementing this role in the field. While this role may initially appear to be mostly technically focused, an effective digital navigator doesn't simply resolve technical problems. They must build a meaningful relationship with patients that sustains engagement and develops patients' intrinsic motivation to use technology to support their health goals. Throughout our training, we emphasize experiential learning through role-play activities that recreate situations that navigators will encounter in the field. This is very similar to other medical education contexts where you use role-play to really just simulate what people will encounter. And we assess our navigators through those role-play activities in which the training facilitator engages in rubric-guided evaluation of competencies. So this is an example of one of the rubrics we use when we're evaluating navigators. It really is designed to guide someone through the process of just taking those soft skills and really evaluating them concretely based on the performance within a given activity. So I'm going to just go through what these modules cover generally, and then I'll pass it off to my colleagues. So this first module, we really ask our trainees, how do I troubleshoot devices and how do I ensure my client knows how to troubleshoot in the future? So because of the ever-changing nature of technology and the variety of digital health tools, we train the process of troubleshooting in itself rather than focusing on specific technical problems. Trainees are taught to resolve technical problems through a dialogue with a patient in order to turn the patient into a collaborator in the troubleshooting process. This is designed to really empower patients to not only solve the issue immediately, but also solve that issue in the future. We also really specifically discuss the digital divide to instill a sense of purpose with our navigators, because this work ultimately is about creating equity within the healthcare space and making that the center of the work is really important for making this an effective role, especially in community settings. We also ask trainees to collaboratively build collections of resources that their communities can use to access technology, such as nonprofits that provide devices. At the end of the session, trainees engage in role-play activities where they practice resolving common technical issues with their peers. In our second session, we really focus on that digital literacy component of the digital navigator role. We ask, how do I assess and teach those digital literacy skills? So in order to prepare trainees to really deliver these lessons, we teach very basic pedagogical techniques, such as chunking up technical processes into steps or conducting regular checks for understanding, things that anyone in the education field is very familiar with doing, but someone who is new to education but is interested in healthcare might really benefit from. So we also introduced trainees to our team's specific digital literacy program called DOORS, or Digital Outreach for Obtaining Resources and Skills, which is a curriculum that builds from really basic skills, such as how to turn on a smartphone, to higher order competencies, such as how to use artificial intelligence and how to identify which images are generated by artificial intelligence. It's kind of a big topic these days, but we integrate it into our digital skills curriculum, and we teach digital navigators how to deliver that to patients. That curriculum can also be accessed freely at digitalpsych.org/doors program if you're interested in implementing it within your own setting. We train digital navigators how to assess overall digital literacy skills and match them with correct learning modules in the DOORS program. And at the end of the session, trainees engage in a role play where they really practice teaching these skills to their peers to make sure we concretize those teaching skills. In our third module, we focus on actually really upskilling digital navigators into digital health navigators, which is to say digital navigators specifically trained to operate within healthcare settings. So we focus on this question of how do I connect clients with digital health tools and support their usage? We cover discussing digital health technology with patients, how to match clients to appropriate tools, and create support plans to increase client compliance with tool usage. Largely, this role is aimed at engagement with digital health tools. These tools can be really beneficial to care, but if patients aren't engaging with them actively, those benefits will not appear. So the digital navigator is really trained to engage with patients, keep them involved in the usage of digital health tools. At the end of this session, they really focus on practicing with each other, pretending to be clients and matching each other with appropriate digital health tools using our Mind Apps database, which is something our team uses to just categorize and find different digital health tools that might be helpful to people. In our fourth module, we basically concretize everything with motivational interviewing techniques in order to really just shore up those soft skills that might be important for a digital navigator to be effective in the field. So we focus on how do I communicate with clients to increase their intrinsic motivation to change. We teach our navigators the fundamentals of motivational interviewing, which, if you don't know, is a clinically developed communication style designed to create a welcoming environment that encourages both education and personal growth. It involves very, very concrete communication techniques, such as open-ended questions, affirmations, reflective listening, and summaries. And then trainees will recur one of the previous activities, applying these new motivational interviewing techniques to the role of digital navigator. So when thinking about implementing this role within an organization, there's a number of different populations that are good to train. So for example, you can train people to serve as navigators for their peers, which is ideal for community settings such as psychiatric disabilities clubhouses, which is a really great pathway for those with lived experience to enter into care roles, especially because these peer navigators have pre-existing cultural competencies as a member of that population served. You can also train students, especially those interested in medical sciences, which is really ideal for research settings that already recruit from these populations. And you can take advantage of their pre-existing research competencies if you're intending to integrate digital navigators within a research project. Finally, you can also train existing healthcare staff, which is really great for integrating digital navigators into, for example, a community health clinic, where our team has trained nurses to do digital navigator work along with their regular responsibilities. You can take advantage of that existing experience those staff members have working with patients and their pre-existing integration into healthcare workflows. So a lot of different options for who can actually serve as a navigator. This training is really designed to be generalized so that the different pieces of it that may be applicable to a given population can be adapted and used to adapt to a different setting. So within our own team, we integrate digital navigators in a number of different healthcare and healthcare adjacent settings, such as our research settings with our digital clinic, our psychiatric disabilities clubhouses that we work with, the psychiatric inpatient unit here at Beth Israel Deaconess Medical Center, community health centers. We have a digital navigator that works at the emergency department in Needham, Massachusetts, and a digital navigator that works in senior services settings, all of which have some variant of this training. So here are just some additional readings and research that was used to inform building this training sequence. And I'm now going to pass it off to my colleagues to talk a little more about the actual implementation and impact of navigators in a number of different settings.
Great. Thank you so much, Mason. So next up, we have Dr. Sean Kidd. So just give us a moment to switch slide decks here.
Okay, thank you. I'll just get my slides up here. Is that...
We can see it, but we can also see all your slides along the left-hand side.
Oh.
Now it's perfect. Yeah.
Now we're good. Okay, great. All right. Thanks so much. It's really wonderful to be here. I'll try and stick to time with basically telling you all a story about the development of a peer support worker as digital navigator program that had its origins in California and Riverside County, related to our technology, which is called App for Independence, which I'll tell you just a little bit about. So funding and disclosures, we've had funding from a range of sources, philanthropic, research, tech-oriented, etc. They're all laid out here. There's a disclosure related to what A4I is as a joint venture between the hospital and Memitex, and I have a small stake in that. And to talk just a very, very little actually, because the topic here isn't so much A4I and our opioid version or schizophrenia version of what the technology does. You can go to our website. The address is in the deck. You'll get demos. You get the whole breakdown on how it all works. But I'll just say very briefly for context that A4I is basically a platform that exists on any kind of smartphone. It's also a portal for clinicians. And it was co-designed. We started with a major focus on schizophrenia. We've expanded out to opioid addiction. But fundamentally, it works like a lot of technologies we all use. It's got a feed There's a peer-to-peer moderated anonymous platform for peers to engage one another. There's sort of CBT-oriented bite-sized feed materials related to psychosis symptoms, anxiety, depression, self-esteem, things like that. General interest stuff comes through the feed. There's a pretty robust reminder scheduler system related to appointments and so on. Gathers data on sleep quality, mental health, all kind of packaged up to put illness self-management tools in people's hands, as well as be able to communicate more effectively with providers with long gaps between appointments and so forth. And we know, of course, there are many technologies if you have anxiety and so forth. But the reason why we built this is just kind of frustration at seeing how little is there for people with more severe mental health challenges. And that's held against the really dire consequences when people drop out of care, don't get the supports they need. And we operate always, wherever you are in the world, pretty much in situations of scarcity where we can't provide in-person CBT for psychosis, for example, only for everyone who needs it. And we'd like to, only about 2% ever get that, by way of an example. So anyways, I'll stop about the tech. You can always check out that in other places and other ways. So John Torres has been speaking and writing about this issue for quite a long time, about kind of the promise and the problems. So he puts it well in this quite recent paper, along with some colleagues, that we've got the situation seems on the surface awesome and promising, right? There's a need, there's a good justification for doing digital health work related to mental illness addictions. The tech's pretty good. We've got some solid technologies out there in different forms. I've got lots of kind of crappy technologies, but a lot of good stuff too. People are interested. Yes, most clinicians, they say, yeah, I'd like tech to be more helpful for me and not just, medical records that we find sort of time consuming and so forth. I'd like it to do more. If you talk to people in recovery, they'll say, yeah, I'd like to use my phone for managing my illness. That's how I started with all this. This guy with schizophrenia I was working with clinically, who was trying to use native apps in his phone to do useful things. However, then you get into the weeds of what we all of us, or nearly all of us who work in digital mental health, we experience constantly, is trying to get these shows on the road is extremely hard. Like we got, they're even on the surface, when everyone seems game and interested, when push comes to shove and you're actually trying to get these things up and running, the unanswered emails, the follow through, the provider fatigue, is minimal infrastructure. Like how many times, probably many people in our virtual room here have engaged a clinical team, and you always have a couple of people who like to play with tech, who are stoked about what you're doing. So yeah, I'll try that out with my folks. But the majority of clinical teams are tired. They don't want to deal with a new thing. And even if they think it's, that's kind of cool, it's like they won't be too interested in doing it. And it's just a slog. And this isn't just digital health. It's hard to integrate any new intervention, behavioral or otherwise. But it's hard, right? So you've got this juxtaposition between a lot of promise, but then also a lot of challenge. And we see that in the commercialization frame as well, it's a lot of efforts that get challenged. So the story I'm going to tell, a super short story here, is if I could be a bit flip about it, it's like, it's the message here, if you take away anything, is shut up and listen. Is really, it's about co-design and engaging partners. And so it's the story based out of Riverside County, California. And, I'm not going to get into, we've done tons of co-design with our technology. I'm going to talk more about co-design with implementation. And really, I think that's why we had a lot of learning here. And you might also be wondering, hey, why is this guy from Canada talking about California? We've deployed in Canada as well as in the States. We have instances in both places, but where we really had some deep learnings on how to get this right, at least for us, was from our colleagues in Riverside County, California. And definitely want to do a shout out to Maria Moreno. And this is the Riverside University Health System there, where we've deployed A4I in an ongoing way for several years. So I've been helping my 13-year-old son out with some math lately. So I thought I'd throw a little transformation calculation in here. I've been having to remind myself about grade 7 math. But it's got kind of have the usual path of getting digital health up and running, which is the picture on the right. But it's transformed by engaging people like the wonderful crew at Riverside University Health System, and then we get the smooth road. So anyways, I'm very proud of this, obviously. So what happened here? So we pitched this through a program called Help at Hand, along with a bunch of other people. And what made Riverside interested in us is we emphasize that A4I, its core architecture can't flex much, but a lot of the content, a lot of the aspects of what's within A4I can be very flexible. We can make it translated to Spanish. We can make it culturally relevant for Spanish-speaking populations. We can tinker with what the feed to clinicians look like. And so in a co-design implementation frame, if you have some flexibility on what you're able to offer, and it's not just a widget to plug in, it really increases the appeal for creative, engaging, innovative people like the Riverside crew here. But most importantly, we did a ton of co-design with them on how to implement, is really trying to understand the technology and how it will fit in their existing system. So we've had quite a few like significant challenges, like trying to drop in, like whether the worst case scenario is you just drop in tech on a clinical team. Hey, use this, it'll be wonderful. Almost never works. And then we've had our research analysts, like Iman, when Iman was working with us, had a long-suffering role of touring clinical teams as an outsider, trying to say, hey, you should do this, it's cool. And then we get the tech keeners, and we had a hard time with it. But here, Riverside has quite a robust peer support system. They're already part of the clinical teams. They're not clinicians, of course, but they are engaged. They're in the system. They love the technology. They wanted to see themselves in it. So they really took on the role of digital navigators. Mason's done a wonderful job of breaking down the kinds of training and elements that go into it. And these peers really took on that kind of a role. And they found it helped them do their job better. It helps them engage folks that they might not otherwise connect with, help get ahead of risk. You see stuff coming up in the feed that's concerning. They're able to do outreach and get ahead of suicidal ideation that's flipping to intent. They can reach backwards to those case managers and psychiatrists who don't have the time or even interest necessarily in doing a lot of A4I stuff, but let them know, if an issue's cropping up. I'll stop there, but it really kind of wove its way in, and that's really kind of what made A4I work in that environment. I'll just show a little bit of data here. So at the bottom are weeks passed since use, and this is our weekly active users on A4I. And if you're familiar with a lot of digital tech, probably many of the apps we have in our own phones, it looks like a triple black diamond ski hill, right? It's like, oh, this is cool, and then you forget about it and delete it a year later. But we've had a good amount of success with keeping people engaged and using the tech that we have within A4I. And this kind of complicated one, what this shows is that the more the peers are engaged, the more people are using the technology. It's that peer engagement, posting on the feed, responding to people on the feed, encouraging people to stay engaged. That really carries the day in terms of keeping people engaged. And at the end of the day, like what's A4I for is to help people keep engaged in care, do better in their recovery process, and ultimately not have all the disruption and tragedies too that can happen when they disengage from care. So where do we go from here with all of this? So Mason laid the ground out really well, like trying to really flesh out this idea of peers as digital navigators. Many conversations here, along with the navigation role, there's also been a thread that's been interesting to track of peers themselves seeing it as a way of propagating peer best practice, is kind of staying tuned in to what are because they see the feed, right? The CBT, relapse prevention, all that good evidence-based stuff pumps out through the feed. They can engage in that. They can engage in one another, because peers can sometimes, if you're the one lived expert on a clinical team, sometimes you lose sense of your role and identity, but this allows you to network better. So that's come up. Multiple bottom lines. So how is this helping everyone do their work better, more easily, more effectively, benefiting patients, benefiting providers, benefiting the economics of the hospital, whether it's in savings, fewer people ending up in the emergency department, and all the massive disruptions in their lives as well. And it's less relevant in Canada, but in states, peer contacts can be billable in many states. So it can enable revenue generation in the clinical frame. And also the last thing I'll say is we continue to grapple with the research approach. I think many of us working in this space started out thinking, oh, you treat it like any other standalone intervention, a tech like this. And we're finding it's messy, right? You do need kind of a complex intervention sort of approach to understand the technology is a tool, but it's also in this frame, a peer support intervention embedded in a system. So the books are still out in terms of how can we properly capture the impacts, and we and I think others as well have found it can be a struggle with kind of your old school standard locked in RCT. Anyways, that's just a super fast spin through the stuff that we're up to, and I look forward to continuing the conversation.
Thank you very much, Dr. Kidd. We'll continue with our presentations, and to those who are observing, watching today, if you have questions or comments, we will take them all at the end. So we have Laura, who is up next. So Laura will be sharing her slides in just a moment. And I just want to acknowledge it's something like 8:30 or 9 p.m. at night in Germany. So thank you very much for making this work.
Yeah, thanks for having me. Can you see my presentation?
Yes, looks perfect.
Great. Yeah, good evening from Germany. So today I'm presenting our pilot study where we implemented digital health navigators for the first time in German outpatient care. And a little bit of background maybe. So Germany introduced a regulatory pathway that allows prescribing and reimbursing digital therapeutics in Germany called DiGAs in 2020. And about a third of them are or have a focus on mental health, actually. So there's a lot of potential to support the German healthcare system in mental health. But unfortunately, as Sean already mentioned as well, the engagement with those apps is also in Germany very low. So 97% of users stop using mental health apps after 15 days, actually. So yeah, digital navigators, as you know, can support patients in using mental health apps more consistently. And they usually help with onboarding, technical issues, and motivation. And we defined the role a little bit. So as you can see, we had a main aim, which was to test feasibility of digital navigators in the German healthcare context. But specifically, we had 4 objectives. So to pilot digital navigators in German outpatient care for the first time, to capture expectations of patients and clinicians, but also to describe the navigator role for the German context and to generate preliminary findings on the effectiveness of digital navigators as well. And we followed a stepwise implementation. So it was a big study, actually. We had 4 phases. We first collected expectations from patients and clinicians to understand what a navigator should do. We then adapted the Harvard Digital Navigator training to the German outpatient context. We then trained the 6 digital navigators, and then the implementation phase began across 6 psychiatric outpatient clinics and GP practices in rural Brandenburg, so close to Berlin. And then we finally analyzed both quantitative usage data and qualitative feedback as well. And here, a very short overview of our first qualitative work. So we found several important points, but mainly that patients and clinicians empathized certain interpersonal qualities, but they also expected basic digital and mental health knowledge, and also awareness of available DiGAs, which is, I mean, there are a lot, over 70, so this was a challenge, and the ability to recommend a certain or a suitable app for each patient. So these expectations shaped the role description for our digital navigators and formed the adapted training curriculum. And here you can see how the navigator support actually looked like in the implementation phase. So first, patients described that actually motivational support was the strongest element. Patients valued encouragement, emotional presence, and someone who kept them engaged when they felt stuck or demotivated. So this is also consistent with what Mason already mentioned. It's not just about technical support, but mainly about motivational support as well. And second, they described individualized DiGA-specific support, so helping with informations and selection, and also just getting started with the app. And a third, practical support was needed, but in our study only to a small extent, because most patients actually did not experience major technical barriers. So overall, the navigator role was experienced less as a technical function, but more as a motivational one in our study. Coming a little bit to our quantitative results, so to capture engagement, we measured DIGA use along 2 dimensions. So first, how often patients use their app and how long each use episode lasted. And we captured navigator check-ins, which ranged from occasional contacts to also several contacts per week. And we observed that higher check-in frequency, as you can see here, was also associated with higher DIGA engagement. So this actually suggests that regular navigator contact can support more continuous engagement with the app. And here we looked at changes in symptom severity and functioning. So as you can see in this regression model, pre-illness severity, BDI, so depression, had a significant influence on changes in illness severity. And a higher DIGA use was linked to strong improvements, especially as you can see on the GAF, which is the Global Assessment of Functioning, and a strong reduction also in depressive symptoms. So the BDI in red here, as you can see. So this pattern suggests that stronger engagement may relate to better overall functioning as well. Yeah, so in summary, clinicians saw that navigators can be relieving or can relieve them from technical and administrative work. This showed in our qualitative work. And also navigator check-ins were positively associated with DIGA use, and DIGA use was also positively associated with functioning. So yeah, together with the expectations and role description works, we can say that digital navigators are feasible actually for the German outpatient care. But it was only a single group pilot with a small convenience-based sample and also only a 5-month implementation phase. So yeah, we would need a randomized trial as a next step to really assess effectiveness. So this would be a lovely next steps for us to do. Yeah, right. Okay, then I hand over to the next person, and thanks a lot for your attention.
Thank you very much, Laura, for that. And just a reminder to folks, feel free to put your questions in the chat so that after the next presentation, we'll start to answer those. So I'll now pass it to Iman, who has already started to share her screen. And we see it in presenter view right now.
Okay, so let me try to reshare. How does that look?
Perfect.
Okay, awesome. Well, thank you so much, everyone, for having us today. My name is Iman, as Gillian mentioned, and I'll continue along the conversation about digital navigators, but we'll focus on the use of digital navigators to support a pilot implementation of a digital platform in the Canadian context. So before I get into things, I just wanted to acknowledge our small but mighty team and also the agencies who funded this work as well. Okay, so I'll be speaking about a pilot program where we implemented the A4I platform that you just learned about from Sean. But in this instance, we implemented A4I into an outpatient comprehensive treatment clinic here at the Centre for Addiction and Mental Health in Toronto, Ontario, Canada. These outpatient clinics provide care to individuals living with schizophrenia spectrum disorders in the downtown Toronto area. And so as you might remember, A4I, or App for Independence, is a platform that consists of a patient-facing mobile health app and a connected clinician-facing dashboard. And the platform ultimately really just aims to support individuals living with SSD and managing their condition. Some notable features, as Sean has mentioned earlier, are the moderated and anonymous peer newsfeed and also the auditory sound detector. And I realize these screenshots are a bit out of date, but Sean shared some of the newer version of what the app looks like today. So in the fall of 2021, we had the opportunity to conduct a small pilot implementation of the A4I platform, where The purpose of this pilot was really to understand the feasibility of integrating A4I into routine clinical care. We ultimately wanted to understand if clinicians and patients would use the app, and if they did, how they use the platform to support care. The pilot implementation was facilitated by two project team members, being myself and my colleague Lydia. And throughout the pilot, we informally took on the role of digital navigators. So in terms of how we set up the project in the summer of 2021, we met with the outpatient clinical leadership team to get their approval and buy-in to pilot the app in their respective care settings. And as you can imagine, this took quite a bit of convincing, just given the time in which we were trying to implement this app. So during the summer leading into the fall of 2021, COVID-19 cases were rapidly on the rise in Toronto, and clinical staff were quite burnt out. And the thought of piloting a digital intervention into their clinics seemed far from appealing, but we had assured them that much of the legwork for implementing this app would be done by project staff, otherwise being the digital navigators. So we received ethics approval and then conducted a rolling recruitment and onboarding of both clinicians and patients to use the A4I platform as a dyad. And once they were onboarded and trained and set up to use the platform meaningfully, they then were asked to use the platform for about 1 year, and we really didn't provide any sort of restrictions or requirements as to how they had to make use of the app. We really just wanted to learn if the app would be used in a very pragmatic, real-world setting by both the patient and clinician alike. And then at the midpoint and endpoint of the pilot, we asked folks to complete a user experience survey, and we also had folks participate in semi-structured interviews at the end. So zooming into what my colleague Lydia and I did to support the pilot implementation, we attended clinical huddles to build awareness of the pilot, and clinicians who were then interested in participating would meet with us, and we would provide them with an overview of the pilot, the A4I platform. We walked through the clinician-facing dashboard with them and then set up their account on the dashboard. We then arranged for another meeting with them and their patient who was interested in trying out the app. And in the subsequent meeting, we met with both the patient and clinician and described what the pilot was, described the A4I app to the patient, and then we then supported them in downloading the app onto their device, logged into their account, and taught them how to navigate the app and personalize the apps for their preferences. The clinician and patient then inputted medication and appointment reminders into the app and set daily or weekly goals for the patient in the app as well. And then once they were set up, they were free to use the app however they wished for 1 year. We would check in periodically just to see how things were going. And we provided them with our contact information as well, like our emails and our phone numbers, so that they could pose any questions to us if they ever needed any support or just wanted to learn more about the pilot as well. And we were also able to monitor engagement with the app through backend app usage data that was gathered. So if we noticed that a patient had stopped using the app for an extended period of time, we would check in with them just to see how things were going and if there was any support that we could provide. So this slide just sort of breaks down the responsibilities of the digital navigator by project phase, so during, and post implementation. And I thought I'd focus on sort of these three buckets of main responsibilities that we took on as digital navigators. So as I described, we dedicated much of our time to recruiting and onboarding clinicians and patients to the pilot and to the platform. The meetings that we held really allowed us to build a relationship with the clinicians and the patients who participated in the pilot. And this really made providing support throughout the pilot much easier, as both patients and clinicians felt comfortable reaching out to us when they needed support or had any questions. And another thing that we spent a lot of time on, which was a bit unexpected, and maybe this is a bit naive of us, but we provided a lot of digital literacy training. So for 3 of the clients who joined the pilot, they did not have access to a smartphone device previously. And thankfully, we were able to provide them with a device thanks to our IT department at KMH. And this was their first time using a smartphone device. So we worked really closely with these clients to not only teach them how to use and navigate the A4I app, but also really teaching them the foundations as to how to use a smartphone. So we set up an Apple ID for some or set up a Gmail for others. We helped them to navigate their device settings. We taught them how to use specific things on their device, like accessing YouTube or searching things on Google, or even adding their clinician as a contact onto their phone, among a number of other things, just to get them confident in using their device. And I think another helpful aspect of our role as a digital navigator was really being that point person for providing tech support and being able to check in with folks about their use of the tool. So from what we had heard, they found it especially helpful to have a dedicated person to reach out to when they had questions about the intervention. And just briefly, I wanted to share a bit more about the implementation. So we ended up recruiting 8 clients and 7 clinicians to participate in this, as I said, very small pilot. We were interested in measuring engagement with the platform, and to our surprise, we had quite a high retention rate, where this retention rate was measured by looking at the total number of app interactions over the first 30 and 90 days. And in terms of user experience, we received generally quite positive feedback from both user groups. So some of which you can see are sort of just demonstrated on the screenshots that we took from the peer newsfeed that some of the clients posted just their thoughts on. And one thing I also just wanted to mention as well was that for the clients who didn't have the best digital literacy skills, their clinicians had initially been a bit apprehensive about whether they'd use the app or find it helpful. But to our surprise, these folks ended up being some of the most engaged users during the pilot. And so just to wrap things up, I thought I'd share some lessons learned. So this implementation of Digital Navigators really highlights the extensive digital literacy support that navigators are able to provide to patients. And this really ensuring that patients can then effectively engage with the digital interventions that we're asking them to use. And as I'm sure many of us are quite aware, digital literacy has commonly been being reported as a super social determinant of health in the literature. So just really demonstrating the importance of building digital literacy skills amongst our client populations. We also learned that although some clinicians had anticipated that patients with lower digital literacy skills would have lower engagement with the app, this implementation identified that providing patients with the appropriate technical support and education really sustained engagement. And finally, while the Digital Navigator role is beneficial, it does require significant resourcing and training and the appropriate oversight. And Lydia and I took on the role of Digital Navigators informally. It was by no means our primary role at the hospital. So if this role were to be formally implemented and rolled out, considerations for funding and governance and training must be made in order to really implement and scale the role across different hospital settings. And so with that, thank you very much. And I guess I'll hand it over to Gillian.
Great. Thank you very much. So you've heard some different perspectives and journeys on the digital navigator role. And Mason, I will correct myself. Digital health navigator was the term that you were using. So I think we'll get started with questions and some dialogue here. And I'm glad to see Mason on my screen because I think the first question we're going to direct to you. Now I see everyone. The first question, and feel free to type these in as we're going, is around how we might distinguish between the role of the digital navigator and general tech support. And there's a comment that a lot of research that this individual who asked the question has read, particularly pre-implementation, is that it typically discusses using research staff or clinicians in supporting with like device setup, troubleshooting, but that they're not necessarily typically described as digital navigators. So are there any important distinctions between these two things? So maybe Mason, if you wanted to go first, and then I'll ask Sean to maybe contextualize some of that.
Yeah, I'd be happy to take that one. So yeah, the troubleshooting and technical support aspect is, I think we think of it as like the foundation of the role. Like anyone who's serving as a digital navigator needs to be able to do that with patients, set up digital health tools with them, especially when it's a research study and there is, a tool that you're using with patients over time. But it's just kind of a basic level of usage for the digital navigator role. That extra layer on top of that is the digital literacy training. So there are additional kind of pedagogical skills that you need to develop to be able to effectively communicate like the really foundational stuff about how a smartphone works, how Wi-Fi works, like these things that might be intuitive to someone who is more of a digital native, but someone who has not been in a digital ecosystem for most of their life might not be familiar with. So a digital navigator is someone who has also additional training as a teacher and is able to communicate those effectively to whatever the target population is for a digital intervention. And on top of that, there's specific training that digital navigators get around health tools. So for example, on our team, we have our digital navigators get specific training on someone comes in to a session with maybe a digital literacy need, but how do you assess what digital health tool might provide additional care to them? So we will match them with digital navigators are trained to do that matching process with them. And that requires, of course, additional knowledge on like basic clinical terminology, what to look out for, and understanding of digital health tools more broadly. So That troubleshooting aspect is a part of the digital navigator role, but there are these additional functions which are higher order that distinguish it from just a simple troubleshooting function.
Yeah, I'm happy to expand a little bit just based on our experience in Riverside, California. So I completely agree with everything Mason said. I think those peer support workers as digital navigators receive some training on how they can do at least the fundamentals of this work. And I should say that general digital literacy is another good part of the bottom line. Like ultimately, we're trying to get help people use our specific technology, A4I, but it really is benefiting everyone. Clinicians appreciate it that people are more able to be more effectively using their phones and for different general circumstances alongside the specific stuff. The only thing I might add is along with the peer support folks in California, it was important to have like a tech expert on the back end because like especially people who are experiencing poverty, many people with severe mental illness they have a huge range of kinds of devices, out-of-date operating systems or Wi-Fi hoppers, like there's a lot going on. And then Apple will keep it interesting by changing their background architecture. And suddenly your technology just stops working with no warning for everyone. So it is helpful like to have, in our case, Wenjie Zhao, who is kind of our tech expert in the A4I and on call, essentially able to kind of quickly engage with the peers, find out is there like a more complicated problem happening with an individual? She can advise on that, or we need to like deal with some whole system glitch because that happens more than you might think, where just suddenly you get a call saying it's just stopped working because something's changed in the background. So I'll stop there.
So I have a question that no one has asked, and I have not given anyone a heads up about. So we'll see how this goes. In many healthcare organizations, whether they be community focused, hospitals, finances are tight. And to introduce a new role, there often has to be the elimination of something else. And I'm curious if you have thoughts on does the digital navigator replace something that currently exists? Is there a way to justify the role so that it can be integrated into sort of the operational needs or operational funding rather than often be funded through research, which is great initially, but the sustainability piece is hard. So any comments or reflections, and anyone can take this, of course.
Happy to get the ball rolling because I think about this a lot. So yeah, I guess it's such a tricky question. I mean, and it's not necessarily, again, unique to digital health, right? As many of us have trialed and developed, been proven in research behavioral health interventions and have an awfully hard time kind of getting them sustainably applied, even when they have a good evidence base. But I guess in this space specifically, I mean, there's some things that you think should work but don't work so well, and that's talking about savings, theoretical savings, right? Is this will result in less EDUs, less kind of crisis management sorts of services, which we know are much less efficient than just keeping people doing relatively well. That people will agree and say that's very important, yes, but it's hard to track in a budget, in a spreadsheet, that there will be savings somehow if we use this technology to some degree. I think making this business case, a few approaches that I think are helpful are like trying to figure out what the pressure points are in a given organization. Like, for example, physicians aren't paid if somebody doesn't turn up, mostly. Some physicians are salary, but most don't. They bill based on being by the person turning up. And so it's very frustrating when they're sitting there and it's a no-show. And they don't make anything that, often the organization can't bill, like all kinds of stuff unfolds from that. So if you're able to show that people will turn up more often. Another facet that we've been learning again in kind of co-design and implementation is optimizing in-person appointments, right? And this benefits everybody. Is somebody's doing really well, they spend half a day in bad traffic getting to the appointment to say, yeah, I'm fine, everything's the same, sure, I'll take my medication, goodbye. That is a waste of everyone's time. Other people, you actually don't want to wait till their scheduled appointment because they're getting sick, they're getting unwell, you want to come in sooner. So optimizing context that makes better use of people's time, I think that's there. And then I guess as well, like trying to figure out structures where like ultimately our end users never pay the people with addictions or schizophrenia, but for the systems like in the United States, there are billable codes related to digital activities like that can sometimes make the case for it. But ultimately, I think it's got to be a bit of a systems level approach. Like Laura touched on in Germany and some other places, these things can start to become prescribable. So the system's paying and they can appreciate maybe some of those savings arguments and so forth. Where for an institution, ultimately, as you say, Gillian, it's a zero-sum game almost always, where if you're carving out a digital health navigator role for whoever, some peer support workers or something, it means somebody else, somewhere else is stopping doing something, and that's tough to tackle.
So the sustainability question is always a tough one, but wanted to at least get it out there such that we could have a think about it and to get the discussion going. A question came in around how much of the benefit of digital navigators is that of a caring person contacting them, which really interesting question. We have two digital navigators here, and I'm not sure that we actually have data on this, but I wonder if you could share your experiences, Iman and Mason.
And maybe share a bit. I definitely think that just that personal connection that the digital navigator can invoke really helps. And I think that's one of the biggest pieces as to why we saw such, I guess, high engagement in our pilot program of A4I, was just because there was that additional person checking in on folks, seeing how they were doing, and just having a conversation with people. We just wrapped up a scoping review of digital navigators in the healthcare context, and we saw this come up a bunch in the literature as well too. It's just, for example, in elderly folks who might be living in isolation, having a digital navigator reach out once in a while was really helpful in terms of just building that sense of connection as well. And so I definitely think that the digital navigator does have that dual support in both tech troubleshooting, digital literacy, but also just being a bridge for connection. And I think Laura kind of spoke about that a bit too, but the digital navigator implementation in Germany. But Mason, I'll hand it over to you.
Yeah, I mean, I would just kind of repeat what you said there in the sense that I would say anecdotally, it is largely the fact that someone who is caring about your digital literacy skills and your digital engagement is contacting you regularly that gives a lot of benefit with the digital navigator role. I think maybe touching a little bit on the sustainability element of it, it is a role that someone can take on as a volunteer or a peer that is able to engage in that engagement process in a way that takes some of that lift off of paid staff members in healthcare settings. So having someone who is able to engage in a way that is appropriate for a volunteer, such as contacting you about your digital literacy skills, where you're at with that, is, I think, very valuable to patients. So I think it's a good question because a lot of that benefit is from that caring contact.
It sounds like sort of digital compassion is at play here. I know we just have a couple minutes left. I think I'll ask the last question to Laura around how you adapted the program in Germany, because if there are folks here that are interested in adapting it to their context, what might that actually look like? What sort of adaptations may or may not be needed? So I'd invite you to respond to that.
Yeah, so for the role in Germany, it was important that the digital navigators could also really give support on which exact DIGA or app the patients could use. And since you've seen, we have 73, I think, right now, and alone 32 in mental health care. So there are a lot of different apps to be able to recommend and know what exactly they can do. So of course they are specified for specific mental health disorders, but they also have certain functions that can match certain patients better. So this was a very important skill that the digital navigators are able to know which DIGA actually would fit a certain patient. So this was a big adaptation that we did, just to match it to the German context. And also it was important that they were able to, also in the same context, to know about mental health disorders. So we also adapted this in the training. And because the motivational part was such a big part in the Digital Navigator role, we also included motivational interviewing, for example, as a training context. So yeah, these were small adaptations that made it more usable for the German context here in Germany.
Thank you, Laura. Thank you, everyone, for your responses to the questions and great presentations. And to the organizers, we've completed this session, but happy to connect with individuals as they're interested in the role. Thank you.
Thanks very much.
Thank you all.